So we are live now. We can start our session. On to you. So, sir, we are live now. We can start our sessions. Over to you.
Should I go ahead?
Yes, sir.
Okay. Very good evening to all my colleagues and friends who are joining me in this webinar. And my special thanks to Lupin guys who have organized this. A very special symposium on beta blockers. So it's a very old drug actually. When you say beta blocker, it reminds us our MD and DM days when we were writing beta blockers left and right. And I can vouch that it was one of the most common drug prescribed in cardiology OPD. But as the evidences started evolving about other medications, especially in hypertension, beta blocker started going to take backseat. And now the latest GNC says that beta blockers are not the first line antihypertensive, but if you see the practicality and clinicians' prescription and clinical compulsions, beta blockers are still, I think, used to large extent than the literature says. So my symposium topic is beta blockers, backbone and stop CVD, but I just briefly the overall blockers, what the blockers are, how are they used, is what is the advantage of beta blocker, and what are the messages from this webinar to me and to my. Can you next slide, please? Next. So, well, this is just a data slide showing data that cardiovascular disease is a #1 killer worldwide and of course in India also. In Indian data, if you see 2016, estimated prevalence of CVD in India is estimated to be almost 54 million. And 1 in 4 deaths in India was because of CVD, with ischemic heart disease and stroke, which are responsible for more than 80% of this burden. Next slide. Well, there are large number of beta blockers and in their indications. Most common in practice is post-MI and coronary artery disease with stable or unstable heart failure, of course, hypertension, non-cardiac surgeries as preventive measure. Then in AF and some tachycardias as a rate control measures, and of course, a very important antiarrhythmic. Beta blockers are one of the most important, I can say, first line antiarrhythmic drugs, especially a patient has heart failure and coronary disease. Next slide. So I'll go one by one. Why beta blockers post-MI? There have been large studies and it has been almost decades and decades of literature supporting use of beta blocker in post-MI patients. And the rationale has been antiplatelet. Why antiplatelet? Because beta blockers are very nicely controlling the sympathetic nervous system activities, and in turn they control the serum cortisol level because of hyperadrenergic state. So they are working as a good antiplatelet drug, and of course they are known as antiarrhythmic drugs and general blood pressure effect. Everybody knows. A very important point about antiarrhythmic drug and heart rate reduction. Everybody knows that lower the heart rate is, better the outcome, better the survival, and better the quality of life. So if you take any parameter in clinical practice, beta blockers score the drugs. Next slide. Can you go to this, please? So evidence of beta blockers started pouring in 1981. You see almost 40 years of a robust data of beta blockers in post-MI patients. So this was the first Norwegian 17 months follow-up with QMI, temolol versus placebo. So, you see, and trial there was 44.6% reduction in sudden cardiac death, is important, and 39, almost 40% reduction in total death. Same was with propranolol, which reduced 26% in total mortality. It was a very landmark trial, beta blocker heart attack trial, in short, because of heart trial in 1982. So 81, 82, the data started pouring in, favoring a huge role of beta blocker. Next slide. Next slide. Well, so continuing beta blocker post-amide. Then another study in 91, then there are pooled data of 1986, you see almost 13,617 patients with a variety of beta blockers, one follow a good 24% reduction in death. See, this is the era when there was minimum revas. And now when we combine revas, PTCA, bypasses, beta blockers have been boon for further advantage in survival. Another trial was in 1986, that was ISIS-1, which again showed atenolol versus placebo, 20 months follow-up, a good 15% reduction. So you name any trial which was with beta blocker, post-amide, I think it saved a lot of life and improved quality and quantity of life both. Next slide. Next slide. Next. So if you use this graph, yeah, effective blockade of mortality among high risk and low risk patients after MI. So this was again a pooled data from 2,01,752 patients post-MI from various abstracts and journals. Mortality determined at 2 years post-MI, and good 34% reduction of all patients received beta blockers. So it gave a very robust data for using beta blockers in every patient who is a deserving candidate for beta blocker. And I think not writing denial of beta blocker was a crime on clinicians' part to all the patients who were deserving to receive beta blocker. Next slide. Next slide. So this is very good slide. This is something like patient with beta blocker, without beta blocker, depending on ejection fraction based on initial EF. You can see more than 50% EF, then 20 to 50% EF, and less than 20%. So if you see the message from the slide, lower the ejection fraction is, better is survival. Go back 20 years, we were really hesitant to start beta blocker in a patient who had LV function of 30%, 25%. Where probably this may worsen EF. But now look at the data. The strongest evidence of beta blocker in reducing the mortality, sudden cardiac death, improving quality of life has been with poor EF. So what is my message is that severe the LV dysfunction is, lower the EF, advantage, more and more advantage of beta blocker is going to get to our patients. Next slide. Next slide. So again, whether it is QVMI or non-QVMI, with beta blocker, without beta blocker, again, so it is not only the type of infarct, the degree of EF, you pool any subset of patients, beta blocker had advantage. So what I mean to say that every patient should receive beta blocker unless contraindicated, especially in the patients who had MI and LV dysfunction. In fact, all patients who had MI, whether Q or non-Q, must be on beta blocker. Next slide. Yeah. So if you can see, it was 975 patients with angiographically documented CAD were followed for more than 3 years. Mortality by whether So in this subset of patients, whether they had MI or not, but they had angiographically documented coronary artery disease, when they followed up for more than 3 years, you look at the data, look at this graph, those who were on beta blocker and those who were not on beta blocker, almost 50% reduction in mortality was there in the patients who had documented angiographically coronary artery disease. So whether it's acute MI, post-MI, LV dysfunction, coronary artery disease on angiogram, take any subset of patient of cardiovascular disease, beta blocker has played a huge role in improving their survival and quality of life. Next slide. A very important point, which I remember when I was doing my DM, when we had to write beta blocker and heart failure, we used to really think a lot. Will it worsen my patient? Will it improve my patients? So it is somewhere in 1997, 98 when we were DM first year, second year students. But now, if we don't write beta blocker, I think we are not giving the advantage of best guideline directed medical therapy to our patients. Next slide. Next slide. So this is the beginning of the story of beta blocker in heart failure patients. Way back in 1985, 50 patients with idiopathic dilated cardiomyopathy with EF less than 30% were randomized. So you see the number of patients. So this was the initial hesitation to write beta blocker in these patients. Randomized to metoprolol versus placebo for 18 months. And result was that low dose beta blockade tolerated by 80% of patients. So this was the first, I think, idea behind writing beta blocker. That will patient tolerate or not get this and for want beta blocker. And then what they concluded that those were on metoprolol versus placebo, the number of death, the number in 50 patients, the death was 3 patients as compared to huge it gave improvement class, NYHA class, the patients were given beta blocker and tolerated it. Next slide. Next slide. Can you go to next? Yeah. So this was another long trial that was metoprolol in ICM. Previous slide. Yeah. So this was again a metoprolol ICM patient, almost patients in class 3, randomized to a dose of 50 to 75 milligram of beta blocker. 1 year follow-up. Primary endpoint was our need for transplant, and secondary endpoint was EF improvement. Next slide. Next. Yeah. So you see there less and more avoided transplant as compared to placebo. So, and the curve, you can see all of patients started getting benefit as early as you can see from here, the curve starts separating, was almost 4 to 6 weeks. The beta blocker effect starts in this time, and you can see the advantage of beta blocker in these patients. Less number of patients needed transplant, and there was better survival. Next slide. Again, there had been definite change in ejection fraction, whether it was very severe category, that is 20, 30, 40%, less than 20% on all patients. If you see the slide, all patients have some increase in because response blunting of sympathetic nervous system. Next slide. Yeah. So if you see this change in functional status, so this is clinically for clinician as well as for patient. This is very important. He is not bothered how much EF has improved, but he is very much concerned to quality of life. So if you see all the data, all the segment, huge number of patients had very much improvement in functional status. Very few had no improvement or very little improvement, but majority of them had either moderate, much, or very much improvement. Those who are on beta blocker. So quality of life does matter in patients who is a heart failure patient or any patient who requires beta blocker. Next slide. So this is a trial. This summarizes majority of trials of beta blocker in heart failure. So it was Merit heart failure trial was between metoprolol and placebo. Comet was between carbolol was metoprolol. Copernicus was with carvedilol and placebo. US carvedilol heart failure study which established carvedilol as another potent beta blocker for heart failure patients. Then CBIS trial, which was CBIS 1, and this was cardiac insufficiency bisoprolol study. CBIS 2, it was the bisoprolol and placebo, and it was a senior trial in patients who were beyond 65 with failure. So all the beta blockers have been used in clinical practice. If you go to summary, there has been huge improvement, quality of life, NYHA class, improvement in mortality, reduction in mortality and morbidity. So all beta blockers were almost. I see the message is that we must write beta blocker. Which beta blocker I have to write? It depends on my own experiences, my conscience, my judgment. But some beta blocker is beta blocker, and then not beta blocker. We should write in maximum tolerated dose because guideline directed therapy says that if we are writing medication in a subtherapeutic dose, the advantage of that molecule is going to be lesser than giving the maximum possible dose. Next slide. Next. Yeah, so this is again a Merit heart failure. So I'll quickly change the slides. This is metoprolol extended release randomized intervention trial in heart failure patients. Next slide. So this was to determine whether metoprolol extended release reduces mortality and combined endpoint of all-cause mortality and all-cause hospitalization in patients with heart failure, that too from class 2 to class 4. So this is what clinically we see in day-to-day practice. Next slide. So the inclusion criteria was 40 to 80 years of age with class 2 and class 4. EF was less than 35% or 36 to 40% with 6-minute walk test of less than 450 meters. Resting heart rate more than 68 beats per minute and supine systolic blood pressure more than 100. So this was the inclusion criteria for this Merit heart failure trial. Next slide. Next. Next slide, please. Can you go to the next slide? Yeah. So if you see the total mortality, again, can see that curve starts separating as early as 3 months. That is the advantage. Mortality reduction starts as early as 3 months, And as you go for follow-up, 12 months, 15, 18, and beyond that, you can find that metoprolol has really outscored with a good 34% risk reduction in total mortality. Next slide. Similarly, cardiovascular mortality has been reduced by 38%. Next slide. Sudden death is very important. There is no drug in heart failure medication which causes maximum impact on sudden death is a beta blocker. Not only that, when beta blocker is combined with MRA antagonist or ARNI, the reduction in sudden death is much more than any molecule in isolation. So what I mean to say that when we are writing RNA or we are writing MRA antagonist, if we are not writing beta blocker in a patient who has indication for the molecule, the reduction in sudden cardiac death is going to be very minimal. So we must include every patient who is heart failure to have beta blocker in their prescription. Next slide. So the deaths from heart failure has been risk reduction was almost 49%. A very good data which supports beta blocker in heart failure patient. Next slide. So then came see when beta blockers were studied, atenolol was first molecule to be studied in hypertensive patients, and then they concluded that it is not a good molecule. Probably, I think we have to revise the strategy. We have to revise the science as the more data is pouring. Now these molecules, like combination of beta and alpha antagonists, that is carvedilol, is one of the finest molecules which we have in beta blocker armamentarium. And it is again a very good drug for being used in patients of heart failure. Next slide. So this was mortality in US carvedilol heart failure program. You can see placebo versus carvedilol versus placebo. Again, carvedilol outscored in progressive CHF and sudden cardiac death. So it was another beta blocker which was supporting the earlier concept of beta blocker in heart failure for survival advantage and progression of heart failure and prevention of sudden cardiac death. So carvedilol data started pouring again, which was compelling cardiologists and clinicians to write beta blocker in heart failure. Next slide. So it was a landmark trial, that is Copernicus trial with carvedilol, and the major question was that can the sickest patient, this class 4 CHF patient, be safely and effectively treated with carvedilol? And can carvedilol therapy be initiated during hospitalization for CHF? So I remember, when we were writing beta blocker, we used to select very stable patients who were almost class 2, forget class 4. We are hesitant to write in those patients. This trial gave answer, kept all the doubts in corner that sickest the patient are getting maximum advantage of beta blocker. Next slide. So it was a good study design with 2,289 patients with LV dysfunction, less than 25% with class 3 and class 4 CHF. They had a mixed population of ischemic or non-ischemic cardiomyopathy. Next slide. The high-risk group it really included high-risk group, that is those who were hospitalized at the time of randomization, hospitalized 3 times or more for CHF within last year, EF less than 15%, very severe LV dysfunction, signs of fluid retention, that is ascites, rales, or edema, required IV positive inotropic agent or vasodilators or diuretics in last preceding 2 weeks. So they are the most sick patients in heart failure group. Next slide. Next slide. Yeah. So patients stabilize. So they are already on standard anti-heart failure therapy. maybe on digoxin or cardron if required. Patients slowly titrated with carvedilol therapy as tolerated, and to begin with, it was 3.125 milligram twice a day, and this up titration was done almost every 2 weeks, and the follow-up was for 2 years. Next slide. And you can see all-cause mortality was much better with carvedilol as compared to placebo. Next slide. Same way, death, hospitalization, and permanent withdrawal of medication was much, much less with carvedilol as compared to placebo. Next slide. Again, effect during a first 8 weeks was maximum. Again, death, hospitalization, and withdrawal in highest risk patient was very minimal. So it was a very nicely tolerated drug, even in patients who were earlier feared of or scared of writing beta blocker, even though they tolerated carvedilol very nicely. Next slide. So this trial proven long, all were proven wrong by this Copernicus trial that, and the reason for this was that lack of appreciation for the disease process, misunderstanding about the efficacy, and excessive concern about safety. So the 3 points which we were hesitant to write beta blocker, and they're all nicely answered by Copernicus trial. Next slide. So the study concluded that even in the most sick CHF patients, carvedilol therapy results in significant clinical benefit. Also, this life-saving therapy can be initiated very early after volume stabilization, oftentimes even during initial hospitalization. So the idea is that try to start beta blocker before discharge, but yeah, you ensure that patient is not wet, he is not fluid overloaded, his lungs are clear, he has no edema. So if you find that he is dry, I think beta blocker must be initiated. Next slide. So there is always a question of carvedilol or metoprolol in heart failure, which is the best. My answer to this is there are certain set of patients where carvedilol is better. There are certain patients where metoprolol is good. There are certain patients where bisoprolol is good. So it is your own experience, your own confidence, and which patient is going to benefit with which beta blocker is a real experience. And of course, we need to have a literature support. Next slide. So this COMET trial was there, which was more than 40,000 patients. The trial was designed to test whether the properties of carvedilol beyond beta-1 blockade have favorable effect on survival. Next slide. So it was a randomization after screening with 50 milligram twice a day with metoprolol and 25 milligram twice a day with carvedilol in class 2 to class 4 patients who were receiving standard treatment including ACE inhibitors. So there are almost 3,000 patients for this COMET trial. Next slide. Next slide. Next. Next slide. Yeah. So you can see carvedilol was a little better than metoprolol in primary endpoint of mortality. Next slide. Again, the cardiovascular and non-cardiovascular deaths, if you see, so carvedilol was little better for first, that is cardiovascular mortality. However, for non-cardiovascular mortality, they were almost identical. Next slide. So cardiovascular death, heart transplant, and hospitalization for non-fatal MI or worsening heart failure. Again, carvedilol was shade better than metoprolol. Next slide. there is always a fear of new onset diabetes with beta blockers, and in this risk stratification, carvedilol was found to be little better than metoprolol, and all that advantage which carvedilol has shown over metoprolol has been because of alpha blocking properties. See why it doesn't cause diabetes as compared to other beta blocker is that alpha blocking property increases the pancreatic circulation also. So with this, there is more insulin and more insulin sensitization, leading to risk number of new onset diabetes. So that was one advantage of carvedilol over metoprolol. Next slide. Next slide. Withdrawal was again almost identical. Next slide. Next slide. So the few slide blocks and see beta blockers for patient for are good stable unstable CAD with angiographically proven blocks. Yes, they are very good molecule, though no trial, much trial, but given some sub studies which have shown that if beta blocker given to patients who have angiographically proven disease CAD, they fared better than patients who are not given beta blocker. Next slide. So this was almost 4,304 patients with angiographically confirmed chronic disease with no HTFCH, no MI. Next slide. You can see univariate effect of beta blockade on death, MI, and death and MI. No beta blocker with beta blocker. No beta blocker with beta blocker. So all subset patients, no post, no but proven it shown reduce death, MI and combined endpoints. Next slide. Yeah, you can see beta blocker has been good for patients who had CAD or angiogram. Next slide. So prescription of beta blocker at hospital discharge seems protected against all cause death or with cause disease, even if they do not have heart failure or MI. Prescription of beta in the patient just appear. So it does not prevent, in fact, but yes, if patient has MI on beta blocker, long-term survival is better if the patient is on beta blocker. Next slide. Next. So I'll just say a few words about this. So whatever trial with beta blocker have been with earlier beta blockers, and majority trial of beta blocker in hypertension has been with atenolol. So there are certain disadvantages of atenolol. That is, one is that it is very short acting, probably given once a day was not able to give protection early morning when the maximum cardiovascular events occur. That is one. Second thing is that atenolol was one beta blocker which was not showing any reduction in central aortic pressure. That is the reason that atenolol was causing more stroke as compared to other antihypertensive drugs. So that was the reason that beta blockers were taken a backseat. But I think it is a bias against them. We have to have few more trials where we should compare the new generation beta blockers with conventional first line, second line antihypertensive drugs. I think that will be a real justification with beta blocker. That is one. Second point is important is that beta blockers, there is a good 25 to 30% of young hypertensives who have very high sympathetic tone. And we have seen in clinical practice, you give them any drug, The moment we add a small dose of beta blocker, their heart rate goes down, their blood pressure is controlled. So I think it is not a written out drug. We have to revise the strategy. We have to have more data pouring in to support beta blocker. Next slide. Next slide. Next. So recent guidelines changes regarding beta blocker and hypertension. So I think GNC7 and GNC7 it was there, but GNC8 has moved beta blocker out of favor. I think maybe GNC9 maybe come with a revision of beta blocker back to first or second line. This is what I feel as a clinician. Next slide. So beta blocker in non-cardiac surgery, yes, they are very important. General anesthesia produces significant sympathetic responses. Perioperative MI is significant in older patients undergoing non-cardiac surgery. Beta blocker is always helpful. Next slide. So there have been some criteria. Class 1 indication beta blocker should be continued in patients undergoing surgery who have been on beta blocker, that is chronic beta blockade. Class 2 in patients with intermediate or high risk myocardial ischemia noted in preoperative risk stratification. It may be reasonable to begin perioperative beta blocker. So we must start beta blocker if we find that some stress echo is positive or some treadmill has doubtful changes, the patient has some class 2 symptoms of CAD. They must be beta blocker. In patients with compelling long-term indication from beta blocker therapy, but no other risk factors, initiation of beta blocker in the perioperative setting is as an approach to reduce perioperative risk is uncertain. A patient is very low risk. He has no risk factors or very minimal risk factors. Prophylactic beta blocker, I think, is class 2B indication. And class 3 is that never start beta blocker on the same day. Surgery is afternoon 2 o'clock. You start beta blocker by 10 a.m. You don't have the time to find out how the patient is behaving on beta blocker. So beta blocker therapy, ideally clinical practice, they should be given at least minimum 1 to 2 days prior to any elective surgery if patient is not on beta blocker. Otherwise, if patient has been on beta blocker, continue the chronic beta blockade. Then class 2 indication is it is reasonable for management of beta blockers after surgery to be guided by clinical circumstances independent of when the agent was started. Class 2B, in patients with 3 or more risk factors, it is reasonable to start beta blocker. So high risk patients, borderline preoperative assessment, and patients who have been chronic beta blockade, they are 3 important subset of patients who require beta blockade. But should be started and should be watched for a minimum 24 hours or maybe 48 hours to see how they behave with the beta blocker. Next slide. So other uses of beta blockers for cardiovascular patients are rate control in AF is a wonder drug, prevention of supraventricular tachycardia, treatment of inappropriate sinus tachycardia, anxiety, neurosis. One of the important addition is beta blocker. Treatment and prevention of non-sustained VT. It's very strong antiarrhythmic drug. Treatment of thyroid storm. See, propranolol is still used in thyrotoxicosis because it prevents the peripheral conversion of thyroid hormone. So it is a still drug of choice of beta blocker in thyrotoxicosis. Next slide. So to conclude, beta blocker therapy continues to be a very important strategy in the management of a wide variety of cardiovascular patients. It remains one of the very few agents that has actually been shown to save lives. The major changes from the past is that beta blockers are now lower priority for the primary treatment for hypertension. So barring hypertension, where it has gone to little backseat, rest all indication, beta blocker is still on the driving seat. Thank you very much. Thanks a lot.
Sir, there are some questions in the Zoom chat.
Yeah, please. So I can read this question.
Yes, sir. You can directly read and answer.
Younger patient with low blood pressure but high heart rate which beta blocker should be prescribed. See, this is a something very important clinically, but I will feel that we should counsel him for non-pharmacological intervention because the blood pressure is borderline, and if you give beta blocker, his blood pressure may fall. So, or we can start very small dose of beta blocker and see how he behaves. See how I choose beta blocker. If I have to change heart rate, bring down heart rate without not affecting much blood pressure, I still prefer bisoprolol. But if I have to bring down blood pressure as well as heart rate both, I prefer carvedilol. Bisoprolol is very good for reducing heart rate, but it has a low effect on blood pressure compared to carvedilol and compared to metoprolol. But in these patients, with young patient with borderline BP, I think I will not prefer any drug. I'll counsel him. I'll ask him to go for meditation, yoga, and I think with this, his heart rate will be controlled. Yeah. See, my opinion for beta blocker in elderly, all beta blockers have been good. There was a depibolol which was tried in senior, elderly patients were beyond 65, 70 in a senior trial, heart failure trial. But Mr. Malhotra, Dr. Malhotra, my answer to this is there should be some beta blocker than no beta blocker. Which beta blocker is best is we have to decide by which patient we are seeing. If we are seeing the elderly gentleman for only for blood pressure and his heart rate is also high, then I'll prefer nebivolol. If heart rate is normal, then I can go for even amlodipine is very good drug. So, but all beta blockers are safe in elderly patients irrespective of their age. So my question, the answer to Dr. Sahani is that role of beta blocker in prevention of sudden cardiac death, which beta blocker according to you is a stronger prevention? See, Dr. Sahani, again, if you go back to forget hypertension, where beta blockers have taken backseat, but in managing sudden cardiac death, beta blockers have a huge role. Even if you go to earlier trial, BHT trial, where propranolol was reducing sudden cardiac death by 34%. So we are blessed to have an era where there has been huge revasc. So sudden cardiac death has been by and large reduced by angioplasty and bypass also. But yes, beta blocker has to be there. Again, if I have to decide beta blocker, that depends on how the blood pressure is. If they have a very good blood pressure, then I will choose carvedilol. If a patient has a borderline blood pressure, I will choose bisoprolol. Metoprolol is in between, but all the three are very good for sudden cardiac death. In acute decompensated heart failure, we should not give beta blocker. We have to wait for patient to get stabilized before writing beta blocker. Like class 4 patient, but those who are not on IV inotropes, they are not on IV diuretics, they have been stable for 48 hours. They are stable class 4 patients, lungs are clear, they are not bed, there are no signs of fluid overload. I think then only I have to start beta blocker. See, CBIS-2 trial proved very clearly that by the time patient is discharged from hospital, patient should be on both molecule, should be on ACE inhibitor, now ARNI and beta blocker. Which drug to start, whether to start beta blocker first or ACE inhibitor is an individual choice. If patient has high heart rate, I'll prefer beta blocker. If patient has stable heart rate, I may start both or may start ACE inhibitors and gradually increase the dose of these two molecules. So this is how clinical guidelines they allow us and guide us to start these two medications. But patient must be on beta blocker if patient has any indication of beta blocker. I think it's almost 5:05.
Yeah, there are no any further questions. So should we wait or should we conclude this session?
Very hectic today.
Sorry.
I had a very hectic day in cath lab. So I think we can conclude the session right now.
Okay, sir. So on behalf of organizer, I would like to thank you for your insightful and educative talks. Thank you for your time, sir. So
Right. Thank you very much.
yeah,
Thank
so
you very much.
ending this session.